Thanks so much for joining us today. This is obviously our weekly Center for Healthcare Policy and Research seminar, where we go over a wide variety of applied research methods and topics. We also support the seminar in public health and some continuing medical education credits. People are here from a variety of different reasons and also watch the recording later. I can't believe we're already midway through February, but this week we're very, very lucky to have Dr. Ladson Hinton join us and to give us a talk specifically on interventions to support dementia with a focus on caregivers in Vietnam. So I'm going to briefly introduce Dr. Hinton and then about 40-ish minutes of presentation and plenty of time for questions throughout, either in chat or hold them for the end of the talk today. Thank you so much for joining us, Dr. Hinton. He's a clinical scientist with formal research training in both medical anthropology and health services research, and he's conducted interdisciplinary research, so interventional research, as well as observational data analysis and ethnography, with a focus on Alzheimer's and related dementia. He has worked extensively with ethnically and racially diverse patient populations in the US and globally, particularly in Asia, Vietnam, and Thailand, which will be the focus of today's talk. And the focus of his career has really been to advance care and services for persons with dementia and their families. So we're really grateful to have you here, and take it away, Dr. Hinton.
Great. Thank you very much, Dr. Lyles. And it's really a pleasure to be here. And I'm going to be sharing with you actually work that I've been doing with a large team over the last 9 or 10 years. And I'm going to try to save at least 15 to 20 minutes at the end for questions, and really look forward to your comments and shares related to what I discussed today. So first, I want to acknowledge this is the work that I've been doing is a global partnership with the Vietnam National Geriatric Hospital, University of Minnesota, and also the National Aging Research Institute in Australia. And there are so many people to sort of acknowledge, but I just want to mention Huong Nguyen, who's been the MPI of the work that we've done that's been funded by the National Institute on Aging. And also to a shout out to Dr. Danielle Harvey, who's been a biostatistician for all of these studies. So she's been a really wonderful collaborator here. So why is this important? This slide actually shows the increase in the number of people with dementia, sort of broken down across high income and low and middle income countries. And on the vertical axis, that's actually millions of people affected by dementia. And what you can see is that as we move forward in time to 2050, by that time, 2/3 of the people with dementia will reside in low and middle income countries. So there's really an important public health, I think, reason for really getting a handle on and advancing care and support for people with dementia, and also preventing dementia, which is not something I'll talk about, but which is very, very important. So just a little bit about, the gaps in care and the importance of this for Vietnam. Like other low and middle income countries, Vietnam's older population is increasing rapidly. It's one of the most rapidly aging countries in the world. And along with that, there are increasing numbers of people with dementia. As we all know, dementia is, extremely disabling, and most of the care is provided by families. And this is even more true in low and middle income countries where there are very few formal supports that exist. Caregiving is also very stressful and costly to families, yet in many low and middle income countries, including Vietnam, there is really little support for family caregivers. So there's an urgent need to develop effective and sustainable community programs for family caregivers in Vietnam and other low and middle income countries. And actually, this priority of developing community-based programs to support families of people with dementia was actually, it's a priority of the Vietnamese government and Ministry of Health. And so we really are following their lead in doing this research to address a problem they think is really, really important. So to begin all this work, actually a while ago, we did a literature review to just see, to look at the evidence base for family caregiver interventions to support caregivers of people with dementia in Asia. And we looked at this across high, middle, and low income countries in Asia. And what we found, and this is a little bit dated, but there's not there aren't a lot of studies that have actually been published since 2017. What we found is that almost all of the intervention studies for family caregivers have been conducted in what are categorized as high income countries in Asia, and most of these were in Taiwan and Hong Kong, mainland China, and very, very few in even upper middle income, lower middle income, or low income countries in Asia, and none in Vietnam. So there's a huge need for this research and to develop this evidence base for these countries. So what we did is we embarked upon a course of research that involved developing what ended up being a culturally adapted version of an intervention that had been tried and tested extensively here in the US called REACH. And so we adapted this for Vietnam. And so the name of this intervention, which I'll be talking about now, is REACH Vietnam, or REACH VN for short. So what is this intervention? So it's based on REACH stands for Resources for Enhancing Caregiver Health. This is an intervention, again, that NIA has sponsored several very large multi-site studies of this. And also the VA system in the US has taken up REACH and developed their own version called REACH VA, which is actually the version that we adapted for use in Vietnam. This is a multi-component behavioral family caregiver intervention. And the components focus on education of the family about both dementia, about the diagnosis, but specifically also about behavioral problems that are really common in people with dementia, things like agitation, depression, even psychotic symptoms. And also, as part of this intervention, there's skill building to help family caregivers manage these behavioral problems and other challenges that are associated with caregiving. And also, because caregivers are at increased risk for depression and elevated levels of stress, there is, as part of this intervention, a stress management component. It's delivered, it's comprised, REACH VA, which is, again, the version that we adapted, is 4 to 6 core sessions over 1 to 3 months that are usually delivered in-home, although the VA has also developed a phone version of this, and then monthly phone check-ins for about 3 months. This intervention is usually delivered by a nurse, social worker, and or a trained lay worker who can deliver the intervention. So our progress to date has included culturally adapting this intervention for use in Vietnam. And then we've conducted 3 separate clinical trials of this culturally adapted version of REACH. And so I'm going to be talking about that now. So to begin this whole process way back in 2016 with an R21, we went through a process to adapt this both to Vietnamese culture and also to the local sort of resources. And we went through a process that there's actually a nice article by Chowdhury et al. In Psychological Medicine that talks about the importance of sort of beginning with sort of a literature review and review of the theoretical sort of framework for the intervention and its appropriateness for the culture. Also formative, a sort of formative research, qualitative interviews with key informants to help adapt the intervention. And then there's a process of intervention adaptation, which can include adaptation to, in terms of language and culture, as well as training of the interventionists and other aspects of the local context. And then what we did is a small pilot case series followed by a pilot cluster RCT to test the feasibility and acceptability of the intervention. And I will say that I mean, this was very time consuming, especially the adaptation to language. This is a manualized intervention. We had to change a lot of the wording and language to make it appropriate for the local population. And I think that doing this pilot case series, which was about six cases, was really important in terms of refining the intervention. And then we did the pilot cluster RCT, and I'll show you the results of that. So these are some of the cultural adaptations we made to REACH as a result of our formative research. And that formative research included interviews with family caregivers of people with dementia in the local community where we tested the intervention, as well as with local healthcare providers and other experts. And so I'm just going to go through this quickly. If people have questions about this, we can come back to it at the end of the presentation. But what we learned is that often people with dementia in Vietnam, and our work has been conducted in northern Vietnam, on the outskirts of Hanoi, and also in Hai Duong, which is a province just north of Hanoi. And what we found is that older adults with dementia are often cared for in multi-generational homes, and often there are multiple caregivers. And so we adapted the REACH intervention to allow, and the protocol to allow for multiple family caregivers to participate if that was desired by the family. We also learned that often the person with dementia is cared for in the home of the eldest son. And the eldest son is often sort of the gatekeeper, so to speak, in terms of care for the aging parent. And so it was really important for us to engage the eldest son as sort of the gatekeeper in order to talk with families about the intervention and to get access to the primary family caregiver, the person doing most of the day-to-day care, who was usually a daughter-in-law, sometimes also a daughter, and so engaging the eldest son was really important. Again, we had to, adapt the language of, the intervention, the protocols to the education and literacy level of the local population. Another thing that we had to do is in the REACH intervention, there was only actually a very small amount of time in the first session that was devoted to education about the nature of Alzheimer's disease. And in fact, it takes up about 20 minutes of the first session in the original sort of REACH intervention. And that's because in the US, usually the intervention is delivered to family caregivers who are taking care of somebody who's already been formally diagnosed. So they often have been in touch with different resources, are somewhat aware of dementia, the nature of the disease, et cetera. But that's not true in Vietnam. A lot of the families that we worked with, a lot of the family caregivers really did not know very much about dementia. So we really had to expand the amount of time devoted to education about the nature of the disease, behavioral problems, et cetera. Um, there also we learned that caregivers, usually women, might often be reluctant to express distress related to caregiving for cultural reasons. That there's a strong sort of cultural value placed on care for the elder, for older adults, for parents, for in-laws. And to openly express your distress about this would not be culturally, sanctioned. And so we had to be really careful about how we communicated the nature of the intervention. So rather than call it an intervention to help family caregivers with their distress, we actually framed it as a way to improve elder care, and that was much more culturally, I think, acceptable. And we also had to spend a lot of time early on in the intervention, really just listening to caregivers and building rapport, gaining their trust. And most of our interventionists also were women. Um, the last adaptation I want to mention is that another thing we learned is that our interventionists, who are often nurses and doctors from the National Geriatric Hospital, at least in the first study, that they often felt quite stressed when they heard the stories and experiences of family caregivers in the community. And so we had to build into the intervention a training for the interventionists themselves, which was based on mindfulness. And my co-PI for this project actually developed that, and we published an article if anyone is interested. So I'd like to now move to to an overview of the three studies that we've done. And again, these were conducted from starting in 2016, and we just completed our large cluster RCT in 2024. And I'll sort of begin with the pilot cluster RCT, which was funded through an R21 through the National Institute on Aging, and also some pilot funding from Global Affairs. All three of these trials sort of share some really common elements in terms of design. They're all cluster randomized controlled trials. We decided that because resources are much more limited in Vietnam for delivery of an intervention like this, that it was important to identify caregivers who were more stressed and target them for delivery of the intervention, just to make a more efficient use of local resources. And so what we did is we had a cutoff on a screener to identify caregivers who were more stressed by the caregiving that they were doing. It's called the Zarit Burden Interview. It's a 4-item screener. So we use that as a cutoff, as an inclusion criteria in all three of these studies. And we assessed outcomes at baseline in 3 months. For the larger cluster RCT that I'll be talking about, we also had a 6-month time point. And I'm really glad we did that, and I'll talk more about that later. Our primary outcomes were both a caregiver psychological distress on the PHQ-4, which is really a combination of both depressive and anxiety symptoms, and also a more expanded version of the Zarit burden interview, a 12-item scale. Also really important in all three of these trials, the comparator, these are all randomized controlled trials, so the comparator is actually control enhanced by education. And I think that is really important in looking at and interpreting our effect sizes. And again, I'll talk more about that later. But just one other note is that, often for caregivers have not had any education, any support around dementia. So even a one session, one session focused on education and a little bit of support that the control group received, I think was significant in this context. But we thought it was really important not to have just care as usual, but to offer something to the families in the control group. So it's for ethical reasons that we decided to go that direction. So I'm going to give an overview of the first study, the results of that. So again, it was a pilot cluster RCT. One of the wonderful experiences with our team in Vietnam is that they were really good at making efficient use of the resources from all of our funding. But from this R21, we had actually originally told NIA that we would do an RCT of 30 family caregivers. And our team actually successfully completed a cluster RCT with 60 caregivers. And that was actually really helpful in terms of taking a peek at some of the preliminary efficacy from this intervention in Vietnam. Our interventionists for the study were very highly trained doctors and nurses from the Vietnam National Geriatric Hospital in Hanoi. We looked at outcomes at baseline in 3 months, and the people with dementia and family caregivers were actually identified through a registry that the National Geriatric Hospital had from this area just outside of Hanoi. They've done a lot of work there, and they had a registry of people with dementia. So that was really helpful in terms of finding people who were, eligible. So what did we find? So these are the results of the study. So the top line, the one in blue, is actually the enhanced control group. And in gray, we see the results for the intervention group. And on your left is the Zaret burden inventory, and on the right, it's a PHQ-4. And so what you see for both of these are two things. First of all, there was a significant difference between the intervention and control groups, with the intervention group doing better statistically. It was a statistically significant result, less than p.05 for both of these outcome measures. But what you also see is that the control group actually improved over time. So on both of these instruments, the PHQ-4 and the Zaret, I should have mentioned this, is that a lower score is better. A higher score means more distress, more burden. So a lower score means, people are doing better. And actually the control group did better over time, but still the difference between the groups was statistically significant. So we did publish this, if anyone's interested, back in 2020 in Alzheimer's and dementia. So now I'll move on to study number 2. So in study number 2, what we decided that the results that we had from our pilot cluster RCT were really promising, and we used that data as preliminary data for a larger cluster RCT. In this study, what we did, we thought it was really important, and one of our consultants, Laura Gitlin, who's really has done a huge amount of work in this area, really convinced us that in addition to doing a larger study, that we should really try to shift some of this work to the community. And so one thing that we did is we actually recruited and trained nurses from the local provincial hospital in Haizhou to be the interventionists for this study. And that was really, I think, in some ways kind of a heavy lift, but something that was really important to do to show or to see if we could actually train interventionists from the local community and have them deliver the intervention, and then see if we actually made a difference. So we did that. For this larger cluster RCT, We also looked at outcomes at 6 months because we wanted to see if we did see, and we were hoping to see, an improvement in the intervention group in comparison with the control group. But we wanted to see if the effects would be sustained, or the impact of the intervention would be sustained at 6 months. And the other thing that I think was significant about this study is that we did not have the benefit of a registry. So we developed a community-based screening approach to identify people with dementia and then recruit their caregivers. And that was really a critical part of this project. And we actually have a paper that's in the works on this. And I think we really developed, I think, a kind of a cool and innovative way to do this in the community. The other thing that I think is important to note is that our team also spent a considerable amount of time and effort, in addition to doing the screening and delivering the intervention, of working with the local healthcare system to strengthen their capacity to both diagnose and support, treat, people with dementia and family caregivers. And when we went back to the community actually last year to present the results from this cluster RCT, a lot of a lot of folks in these clinics and leadership, they were really so pleased with how our team from the National Geriatric Hospital actually helped them become more more competent, more aware, more educated about how to treat families and people with dementia. So we had the challenge of actually doing this cluster RCT during COVID. And so what you can see here is the blue line is what we projected as our recruitment, up to 350 dyads. And the orange line at the bottom is the actual recruitment. And basically our whole study was shut down for about close to 18 months. We didn't do any recruitment. We had to stop. We had started the intervention. We had to sort of halt it. And our team was tremendous. I mean, we managed to actually complete this large cluster RCT, on more or less on time during the 5th year of our grant. So we were really pleased with that. So this is the consort diagram. I'm not going to go through this. This has been published if anyone is interested, and I'll give you the reference in just a moment. But overall, this was of 350 dyads, about 41 clusters. Our retention rate was really good for both the control, enhanced control, and also the intervention group. And we screened about 1,200 people in the community, and older adults. And we then screened about 660 family caregivers in order to get this sample of 350 family caregivers. So these are our results from this larger cluster RCT. So it was really interesting. What we found is that for the Zaret burden inventory, so the caregiver's perception of the burden and stress of caregiving, there was a significant decline compared with the control group from a baseline all the way to 6 months out. In fact, the difference was the largest at 6 months. So that effect was sustained. However, for the PHQ-4, there was initially at 3 months, there was a lot of separation and improvement, but there was an attenuation of those treatment effects or the intervention effects at 6 months for the intervention group. And so at 6 months, there was no longer a significant difference between the two groups. And we've talked a lot about the reason for that, and I'll get to that in a moment, but and about how we plan to address that in our next study. So we did publish this. We were really fortunate to get the result. We finished the study in 2024. We wrote it up actually, very efficiently and quickly. Many thanks to Danielle Harvey for all her work in doing these analyses. And we got it published before we put in our competitive renewal of this grant. So we're really, really pleased with that. And so there's the reference for anybody who is interested. Let me just go back and just touch on this issue of I can't resist right now of this attenuation of the effects at 6 months. And one reason we think this might be the case is that our intervention is basically delivered during the first 3 months. That's most of the intervention. And then there's some very brief phone follow-ups from 3 to 6 months. And so our feeling is that probably that from 3 to 6 months, that's not enough, at least to sustain the effects, the treatment effect for the PHQ-4, which is depression and psychological distress, and that people need more robust boosters, so to speak, from 3 to 6 months in order to sustain, the treatment effects. And again, that's something that we're going to be looking at, hopefully, in the next study. So I'm going to very quickly mention our third study. This was actually an administrative supplement to our R01. And this was motivated by, in many ways by COVID, because we realized that, gosh, it might really be important to have a phone version of this intervention that could be, that could be tested, that could be eventually sort of implemented and disseminated in Vietnam. So we basically we did a pilot cluster RCT of a phone version of Reach Vietnam. Our team felt it was really important to have one in-person visit and followed by several sessions delivered by phone. And so that's how we structured it. An initial in-person and then 3 to 4 phone calls. Again, outcomes were assessed at baseline in 3 months. And the interventionists, again, were sort of experts from the National Geriatric Hospital. And so the results of this are actually pretty similar to the initial pilot cluster RCT and also the larger cluster RCT, in that at 3 months, there was a significant difference, improvement of the intervention group in comparison with the enhanced control. In this case, interestingly, in contrast to the first pilot cluster RCT that we did, the enhanced control group actually got a little bit worse over time. They didn't improve as they did in the very first study. And one reason for that is that for this cluster RCT, the control group, their single session of intervention was delivered by phone rather than in person. In our first pilot cluster RCT, the control group got an in-home visit by one of the staff who did some dementia education, and so that could be that difference is what is responsible for here. In the second pilot cluster RCT, the control group not doing as well. They did not get that in-home visit. So the summary of the key findings from these 3 studies. First, I think that we have some pretty good evidence that our intervention, Reach Vietnam, is efficacious from these 3 cluster RCTs, all in different locales in Vietnam. And this is with a total sample of about 470 caregivers. So we really have, I think, done a lot of work in Vietnam and have quite a bit of evidence that this intervention works. And also, we think it's really significant that phone delivery appears to be effective. That's more cost effective, and we think that that's really important for future scale up in Vietnam. As I mentioned, booster sessions may be needed to really sustain the treatment effects, especially for depression, for psychological distress at 3 months for family caregivers. And the last thing is that, and I'll show you a slide on this, is that when we look at the effect sizes, they were reduced with a shift in the larger cluster RCT to community interventionists, the nurses from the local provincial hospital. And so this actually compares the effect sizes across these three different studies. And they were pretty robust for both of the pilot cluster RCTs, but for the larger cluster RCT, the effect sizes were more modest. I think more similar to the effect sizes for REACH in the United States tested with different populations, including ethnically diverse populations. So our next steps, we hope to build on the work that we've done and to conduct a hybrid type 2 implementation effectiveness trial in Vietnam. And we've worked very hard with our colleagues in Vietnam to try to figure out how we can actually implement our intervention and have it be sustained in the country. I mean, that's really that's the big prize, right? Is to actually take your intervention once you've shown that it's efficacious and to scale it up and sustain it so it really can be broadly accessed. And we're really excited because the social work delivery system in Vietnam is being developed. The government is putting a lot of priority on that, a lot of resources into that. And that ministry in Vietnam is really interested in incorporating our intervention into the social work system. And so what we've proposed is a large hybrid type 2 trial to look both at implementation outcomes and also effectiveness outcomes and to look at costs for this next stage of our work. So I wanted to kind of conclude by just briefly mentioning the NIA, National Institute on Aging stage model of behavioral intervention development and testing. And this is kind of nice. They really have promoted this at the National Institute on Aging. Most of the grants go in. Really, you really have to use this language to talk about the nature of your intervention and what type it is. And our work has actually, we began with sort of a stage 1-2 trial in which we did, intervention. We didn't really generate the intervention, but we adapted it, did that formative research, and then we tested that in the community. And we were powered to do an efficacy trial. And so a lot of our work has been stage 1-2, but the larger cluster RCT is a stage 2-3. And so we were still focused on efficacy, but we really tried to move our intervention into the community and use the community nurses as interventionists. And in this next phase of our work, we're hoping to really move to it's what would be classified as a stage 4 or 5 trial at a behavioral intervention trial according to this framework. And so we're really excited about that next step. The one other thing I like about this, and I think is really helpful, is that if you go around the outside of this, it looks kind of linear, right? You go stage 1, 2, 3, 4, you go around the circle. But, sometimes what happens is that you might do a stage 4 trial and things don't work so well. So you've got to go back to an earlier stage of behavioral intervention development. And so I think this is really just a helpful, flexible way to think about the intervention development and testing process. My last slide. So just sort of thinking back about our work, we really began this all in 2016. This is, you all have probably seen this before, but it's sort of the 17-year plus odyssey from the development of an intervention to the actual dissemination into the community, into practice, and affecting much larger numbers of people who are afflicted with, say, dementia and also family caregivers, but for any disease. And so it takes a long time. And so we've been at this work now for, almost 10 years. And, if we're fortunate enough to get this funding for this hybrid 2, trial, maybe within 12 years, we will have the data, 12 or 13 years, the data necessary to really scale this up on a national scale, actually in Vietnam through the social work system. So, um, thank you very much. And this last picture actually is one of my favorite spots in Vietnam. This is from Halong Bay. If anybody has been there, it's up north of. It's actually very close to Hai Duong, north of Hanoi. So I'll stop there and open it up for questions.
Thank you so much. That was so great. And I want to visit Vietnam now. I've never been.
Yeah, wonderful, wonderful people, wonderful food. I
Yeah.
highly recommend it. So.
Um, I have several questions, but I'll just get one started while everyone else is getting their thoughts going, and you can put them in the chat or unmute. We have a small group, so don't feel shy. And this, if you're here for continuing education credit, this is the link, just so you don't lose that in our discussion. My question for you, well, I had a comment and then a question. My comment is actually that in my role at the CTSC, we've been standing up an implementation science works in progress group, and I wanted to extend the invitation for you to come join come join us and maybe
I,
present some of your work, especially
I'd love to do that.
Okay, great.
I probably should have. I was remiss in not doing it earlier. It probably would have
Yeah, well, it's
helped our
new.
last grant. So
It's new, and so I want to say that publicly for anybody else on the call as well. Um, a pretty growing but moderate-sized group of individuals trying to get grants or publish in the space of moving into the hybrid trials and think about implementation science in our own institution. So I wanted to say that. And then related to that, I was curious about what you powered your new proposal on in terms of your hybrid outcomes for the implementation, especially to give people an idea of what it looks like when you leave that clinical effectiveness or you pair the clinical effectiveness with some more implementation outcomes. If you could talk more about that piece.
yeah, I'm happy to do that. I will. I just wanted to. I really look forward to connecting with that group at the CTSC, and I will say that this last grant that I wrote for this trial was really challenging for me. I mean, writing an implementation science grant, it was like a new landscape for me, and it really was very, very challenging. And we actually ran into challenges thinking about the implementation outcomes and how we were going to power them. We went back and forth. And that was really challenging. And what we ended up doing is hanging our hats on the clinical outcomes, that we already sort of had some effect sizes. And we sort of used that in order to determine the power, for the study. I wish Danielle Harvey I don't think she's here, but I wish she could speak to this. But that's what we ended up doing, but it was not really entirely satisfactory to me, because I thought that the implementation outcomes were really, really important, but I could not find any great guidance on this,
Yeah,
and so.
very
Um,
common, I would say. But so quick follow-ups on that, and then I do want people to chime in. First is, why didn't you consider a type 1 with the effectiveness being the primary? Because so just for anyone who doesn't know about implementation designs, as you get further down along that pathway that Dr. Hinton's talking about, you then prioritize implementation outcomes more strongly in your designs. And there are generally 3 types where you're still have an effectiveness outcome, a clinical effectiveness outcome, and you add an implementation outcome as more secondary, but you power it on the effectiveness. I think what you said was yours was co-designed with a co-effectiveness and a co-implementation outcome. And then the third is to actually power it and work explicitly on the implementation outcomes first, and then to have the effectiveness kind of be second. That's my conceptualization of it. But I was just curious if you could say what specifically was your implementation outcome that you were thinking about or that you wrote about in the trial.
so I think your question was, why did we choose a type 2?
Type 2, and
Or-
what can you give an example of like the implementation outcome that was hard to power? What it specifically was it? Was it like adoption, a number of clinical, what was the actual measure? That would be great. Both of those I think would help people visualize what
Sure,
it looked like.
sure. One of the things that we thought was really important were the implementation outcomes related to fidelity. And it was just really hard to figure out how to power those. We could not find other work that had been done that really would provide guidance. And so that was just an example of one implementation outcome that we thought was really important. And it was difficult to know how to power that. In terms of why we chose a type 2, we really felt that from these 3 clinical trials, we had pretty strong evidence, of efficacy. And we really felt like to make a difference, in Vietnam, that we had an opportunity to really implement. And we really wanted to learn more about the implementation process. So we thought that both getting the effectiveness data on the clinical outcomes and also doing something robust in terms of implementation was really is what we wanted to do. So maybe at the next step, we really would be looking at dissemination, no longer at implementation. So
Yeah, I love
you
that.
know, I don't know, maybe, on a personal note, maybe part of it is because, the older I get, I feel like I have less time,
Yeah,
in the
you don't
field.
want to
So
wait. Yeah.
I don't want to, I don't want to do 4 more studies. I want this to be hopefully the study that gets us to the point of dissemination. And then, so I don't know if that's a satisfactory answer, but that's the one I've got.
Yeah, I think the reason I was pushing on those is that everyone, I think, when they come or talk to us or in the group, always is struggling with the same things. Like, when is it ready for the types of implementation outcomes? How long, do you have to do you have to prove effectiveness in more sites, like in social work first with effectiveness and then add implementation, or can you jump and do both at the same time? And the reason
Yeah.
I wanted you to talk it through is I don't think there's a right or a wrong answer to
Um,
that, and I think it is squishier, and that's part of the fun of
yeah.
implementation.
And we went back and forth.
Yeah,
I almost wrote this as a type 1.
yeah, yeah,
And so we really went back and forth and yeah, so
yeah. Because I love the cycle, I love the figure, but I also know in real life, it can feel stuck in between kind of the phases and try to have clarity in what you're trying to propose. So that's really great for you to. It's lovely to see a whole body of work actually in one talk and see how it progressed to that. And hopefully we can get even faster than 12 years. With 17 to 12, maybe we can get a little faster even in the
yeah.
um what other questions we have still 12 more minutes. What other questions do you have for Dr. Hinton or about these kinds of methods or outcomes? Anything? Quiet group today.
Or I'll throw out a question too for the group, and
Yeah.
that is, that one of my interests is doing global mental health, and so I don't know if any folks here have, any experiences they'd like to share about working, globally, and doing intervention work. So.
Yeah, I'm looking around to see. In Chipper, we don't have as much global work. I don't know if anybody else wants to chime in, but a lot of what you discussed, all of my cluster interventions, hybrid trials for implementation outcomes are in safety net healthcare systems in California. And so a lot of what you described reminds me of some of the resource limitations and just the adaptations needed and the creativity involved. I mean, those are very constant themes for all of the
Mhm.
trials that I've done. I know it's not global, but I always think a lot about how, well, to be very honest, we have a very tiered healthcare system in the United States, and working in systems that have a different approach, it feels like a lot of the same things I read from the global health literature apply, right? In terms of how to use staff in different ways, how to make use of the intervention, I heard a lot in your comments too about how to align it with other things already happening in the system to make it feel more seamless and aligned with their overall goals. Things like that are all
Yeah.
very common, yeah, in the types of things I've done.
Yeah, I mean, I will along those lines. Way back in 2014, when I really started to work in Vietnam, actually, when I began my work, I was interested in doing collaborative care for depression and older adults. That was the thing, and I had actually spent quite a bit of time working on that just before I began this work in Vietnam. And I actually went to Vietnam to the National Geriatric Hospital and presented on the work, the collaborative care model. And I thought, gosh, wouldn't it be great to go to the primary healthcare system in Vietnam and really try to do some of that work in Vietnam? That was my idea, right? So I took it there and I gave a talk. There were, of course, they got a large group together, and then the director, his name is Dr. Tong, who's really sort of a really well-known. His father developed the field of geriatrics in Vietnam, and he is also a geriatrician. And so we went up to his office, and in his very, of course, very polite way, he said, first he complimented the talk. He said, "That's wonderful." He said, the collaborative care model is and depression, that's so important for older adults. And then he paused and he looked at me and he said, "But what about dementia?" And that was a pivotal moment in my work in Vietnam, because what I realized at that moment was the in-country priorities did not align with what my sort of priorities and agenda was, sort of walking into that cultural space, so to speak. And so what we had to do is we had to adjust very quickly. I had not actually led an intervention study for caregivers, and I got together with my collaborator, Hoong Nguyen, who is at the University of Minnesota. She's really interesting. She's both a Buddhist nun, but also an associate professor, and she's fully bilingual, was born in Vietnam, so she's very culturally embedded. But she and I got together and we said, well, we've got to try to do dementia and support caregivers. That's what they wanted, was community supports for family caregivers. And so that's what we did. But, I think that really was one of the keys to our success, because we were really writing, we were really following their direction in terms of what they wanted to do and what was important. And so that was one of the most important, kind of a basic lesson, right? But thank God I didn't, sort of continue along those lines, sort of parachuting in and with my priority and trying to get it all done. And that wouldn't have gone anywhere, I don't think. So anyway.
Yeah, I love that. Very reminiscent of my own career as well. Like you think you have an idea, but it's really what other people want to work on. I had one more question in the chat that you just started on, just seeing if you have anything else to expand on. That sounds like a challenge that you overcame in terms of you presenting your idea and then pivoting to a new idea. But maybe you could talk about how you found the collaborators and how you got involved with local government and sort of those basic steps too.
Yeah, that is really important as well. And before I forget it, actually, it's on sort of a different topic, but a great resource for anyone who's interested in pragmatic trials in dementia, caregiving, people with dementia. The, it's the NIA Collaboratory, and they have a website it's a collaboratory funded by NIA to implement best practices for care of people with dementia and also supportive family caregivers in our healthcare system. Got a lot of tremendous resources there, if anybody's interested. So just want to make sure I didn't forget that. It's so the short story is that my mentor from Harvard when I was at Harvard was Arthur Kleinman, who is sort of a leader in the field of medical anthropology, global health, psychiatry. And he came out to Davis and actually gave, I don't know, it was 2007, 2008. He gave a talk, and we spoke, and he said, he said he basically gave me a small pilot grant from the Harvard Asia Center to just go to Vietnam and find out how that country was dealing with a growing sort of, elderly population. And so I went back there. And one of the things I wanted to do when I was there was to find a collaborator, to do some work. And the first person that I connected with, I actually found him through his publications, which looked really good and on target. And that collaboration, so we met in Vietnam, he came to the US a couple of times. It really was like a year and a half of kind of trying to develop the collaboration. It was not a good collaboration. it turned out not really to be in some ways sort of a waste of time. Luckily, through the Harvard Asia Center, there was a meeting, and I actually met Hu Nguyen, who had tremendous connections, and she connected me then with the National Geriatric Hospital, and said, "This group is really good. You know, they're really committed. They're great to work with," and that was absolutely true. So that's how I found this group at the National Geriatric Hospital. And that's such a critical piece in developing, any collaborations, but globally, because so much of the work has to actually take place when you're not, in country. When you're here in the U.S., we do a lot of our work. We have endless Zoom meetings at odd hours of the evening, to do this. But you've got to have a group that you trust, that's really good, that's committed, and we're really fortunate to have found that group, but it was really kind of through word of mouth and connections. It was, and I sort of, muddled through that and really wasted like a year and a half. But thank goodness I found some good collaborators. Thanks for that question.
Yeah, that's a great true example of sort of being open. It sounds like cold emailing some folks, using relationships, then being open when you're there and pivoting and all of those kind of components. And take some time to find the right collaborators. Um, this has been really wonderful. Unless there's any other final questions, we might give you a couple minutes back. We just really appreciate taking the time to be with us today. Thank you everyone for joining us, and yeah, join us again next week as we continue on our winter quarter series. Have a great day. Hang in there, everyone.
Okay, bye-bye.
Bye. Thanks again.